So for people or post-prophylaxis exposure, post-exposure prophylaxis, and then these people exposed to the confirmed cases of COVID, no? And so you still have the same dose of the ivermectin, but you can increase that up to 5 days, 7 days. I know you have to have that level of comfort to increase the medication. This is only day one and day two. Every day, uh, of course, if the patient develops symptom, then you will continue to treat them. And it's still the same supplements for immune boosting. Okay. And this is the early treatment for mild COVID symptom. Okay. So this is the phase 2, right? All the other prophylaxis are from phase 1. So this is where you have to start checking your oxygen level or saturation. So the pulse ox is a very, very good and practical device, because you can monitor and monitor the oxygen. That will tell you when to be very aggressive in treating the disease. Because you see here, it's still the same ivermectin point 0.2, but this should be adjusted. It should be point 0.2 to point 0.4. Okay, that's the latest recommendation. And then the treatment should be minimum 2 days, but you can extend it up to 7 days, 5 or 7 days, depending on the response and sign and symptom of the patient. When the patient is getting sicker, I'm increasing the dose of the ivermectin. Okay, if I started at point 0.2, I'm going to go to point 0.3, and I'm going to go to point 0.4 when the patient is very symptomatic. And as you can see, the doxycycline was also added here, and you can take that between 7 to 10 days. I usually use 10 days. Okay. Vitamin C, higher doses. As I said, whatever your gut can tolerate, then you take higher dose of vitamin C. The vitamin D3, now they we increase it to 5,000. You have to be very comfortable using this. When the patient gets sick, I load them up with 10,000 every day for 3 days, or sometimes 50,000, for 2 consecutive days. But it depends. I have the luxury of taking the blood test to see what is the vitamin D level. I can do it very quickly. And so, the level of comfort when I use the vitamin D is very high. And after using it for a long time, even without the blood test, I can go very aggressive with a dose of this. But you have to have your own level of comfort. I have so much experience with vitamin D. I've been using vitamin D since high dose vitamin D since 2006, I think, 2006, 7, 9, something like that. And in the beginning, the other doctors in the area, they are telling me that I'm a little bit crazy using that much. But anyways, the patients are taking it and they're well. Okay, with the zinc, you have to increase 50 to 100 milligrams a day. Okay, and this is until the patient is well. And then the aspirin, you have to use 325. 325, if there are no contraindication, 325. Again, the melatonin is increased. This should be increased to 10. Once the patient is symptomatic, you have to use 10 milligrams. Oh, this is 3 times a day, so that's good. Okay, but the thing to that is, don't make it 3 times a day. Promise. Just take it at night, because if you take it 3 times a day, you're going to be walking around drowsy. Okay. So um, uh, there's the recommendation 12 to 24 milligrams at bedtime. Okay. So in the Philippines, we also recommended that you can use the inhaled Vedusinite, which is 200 micrograms per dose. And so you have to take, you inhale the puffers. It's a puffer. You inhale the 2 puffs or 2 actuation twice a day. And for some reason, it's recommended here in the Philippines, 65 years old or 65 years old, or somebody who's older than 50 years old. My patient here, I see a lot of lung patients. So this agent, the Vedusinite, I'm already using this agent with them, not only in the inhaler, but also in the nebulizer. You put it in that little container, and then we have a nebulizer machine. I give my lungers, especially the advanced one, I give them all the nebulizer at home, so they already have it at home. Okay, so sometimes I use slightly higher than that as well, because I treat the advanced or the severe COPD with this agent. Okay, and now the moderate COVID disease is supposed to be in the hospital already, but we put this out when we formulated this intervention, because your hospital is so overwhelmed, and I'm not sure if it's still so overwhelmed right now, that people are dying in front of the hospital. So you can start this, but I would really want to emphasize that the doctor should be involved. Okay, because that's where you're going to be using the ivermectin and all the supplements and all, and then here you're going to use the actual corticosteroid. Okay, you have to take it by mouth. That's the recommendation in the Philippines. And then, or you can use dexamethasone. Again, as I said, as a pulmonologist, I like the methylprednisolone, just because of the better lung tissue penetration. Okay, and I, as I said, in my setup here in Florida, I can give this IV, and it's so much more effective. I hit them with the IV, and I give them slightly, I mean, much higher dose than that. Again, the doctors should be comfortable using this. You have to have that level of comfort. But when the patient is symptomatic, please don't, even if you don't have that level of comfort, you have to do it, because this is the thing that's going to save the patient. Is going to save the patient, is going to stop the patient from going to the hospital. Obviously, there are patients who are not going to respond, and so either, number one, if there are no hospital, you have to keep on increasing the dose, or if they can get it from the outpatient and get a shot, because you can give that IM and you can give it intravenous push. Okay, so both of this you can give intravenously. So you keep on increasing until the patient gets relief. The response is within 24 to 48 hours. Promise. Okay? So when I give a higher dose IV, especially, the patient comes back to me the next day and they already have relief. And also, you're going to see the oxygenation is going to start improving. Okay? 24 to 48 hours. Don't hesitate. I'm talking to the doctors. I'm talking to the physician, and patient, if they're not giving it to you, ask for it. Okay? All right. So this is my, this is what I do. This is my actual things. My protocol in the outpatient. Obviously, the number one, I always use the immune boosting supplement, micronutrient, nutraceutical, and I adjust them and give them different doses depending on the need of the patient. It makes a big difference if you have a background in functional medicine or orthomolecular medicine. That's one of my specialty also, aside from pulmonary and critical care internal medicine. That's my special interest, functional medicine and anti-aging medicine, and use of nutritional supplements and micronutrients, nutraceutical. The use of those is a very big thing in that type of specialty or background. Again, I use the ivermectin. I'm using now between zero point 0.2 to zero point 0.4 milligram per kilogram. And right now, I'll tell you, the cases have declined considerably, and a lot of my patients are already vaccinated. But what I am seeing, it's not a lot yet, but the younger people coming in that after the vaccination, they are getting infected. And I think it is the variant. So I would give them just the same, the ivermectin and all the rest of the supplements and the and I use doxycycline for the most part and not a Citromax. But you can use either one of this. And older people, you just have to be careful. You have to monitor their, cardiovascular medication, because there are certain medication that the azithromycin or the azithromycin will increase the level. So you have to just be conscious about that. I use monoclonal antibody. I don't think that you guys have this, not even in the hospital. The monoclonal antibody, if you are following the US politics, this is the antibody or monoclonal antibody, the agent that was given to President Trump, okay, and other politicians who got infected. We have monoclonal antibody, and these are basically cocktails, right? And we have the Eli Lilly and the Regeneron, and both of them are under, we use this under emergency use authorization. And actually, I get my supply from the Department of Health. They have a, I just have to call them. There is somebody who's, what do you call this, responsible for distributing, and we get 58 doses every week. That's how much I can get. Actually, right now, since I haven't been seeing a lot of the older people getting the COVID, so I have a lot in my office. I wish I could give you some. Uh, and the indication for monoclonal antibodies, again, they are, you have to be 55 and above with comorbidity. So, or any age, as long as you have the comorbid condition, okay? So I can give this as young to somebody who is as young as 12 years old, as long as they are at least how many kilos? More than 33 pounds or 15 kilograms, or much more if much better if they're at least 40 kilograms. So the youngest that we can give the monoclonal antibody cocktail is like as young as 12 years old. uh, Trump received the one from Regeneron, the well, it's a tongue twister to pronounce all this. Bamlanivimab, etesivimab, caricibimab, and dibimab. And if the requirement is for giving this is to pronounce the the name of the monoclonal, then nobody will qualify, huh? So anyway, so I use steroids, the corticosteroids, and then my favorite is methylprednisolone. I give it orally, I give it IV, I give it IM. When the patient is already a little bit hypoxemic, they come to the office, they have more cough and all that. Even without the x-ray, I give them intravenous. I just shoot the patient. I give the intravenous methylprednisolone. But for those people who don't want the methylprednisolone IV or IM, and it's very rare, they want to feel better and they will just take whatever. Okay? When they know that they have the COVID, they will take anything. Okay? So for anticoagulation, one thing with my patient, a lot of them are cardiac patients, so they're already taking uh, um, what do you call this, the factor 8 inhibitors, which are like the Eliquis, the Xarelto, Pradaxa, things like that, or they're also on aspirin combination. So by default, they are protected because they're already being anticoagulated for another condition, okay? But obviously, if you are not, you're a relatively, a healthy person and what do you call it, a little overweight. The obese one, I always anticoagulate. It doesn't matter whether they have a comorbid condition. I anticoagulate them. They are very high risk for forming blood clots. Okay, and I require everybody to have the pulse oximetry to monitor their oxygen level. And then again, it's a luxury for me because the blood tests I can do them anytime. Any blood test that they do in the intensive care unit, I can do in the outpatient. So in essence, the aggressiveness that I do, I bring the ICU management into the outpatient, whatever I can, but you have to be comfortable using them and the combination of these things. Okay. So I even use for the anticoagulation, sometimes I use this Lovenox, the low molecular weight heparin. I use that. I have that too. And then, so in the blood test, if you do the markers, you can further stratify the patient. So the patient comes in, you know that they're old or they are obese and they have coexisting high risk condition. And then you get the markers. And when they are very high, then you can predict that this is the patient who's going to go bad. And so you have to be aggressive in whatever you're doing. So they're going to go bad. A high D dimer makes the patient very susceptible or very high risk for forming blood clots. The anticoagulation, I kind of extended a little bit more, even up to the long hauler stage, because as long as the D dimer is high, I will protect them from thrombosis or for blood clots. And the main thing, they have easy access to me. I'm not the only provider in my practice. I have two nurse practitioners who are helping me, and they are what we call mid-level providers. And so when the patient is getting bad or they have symptoms, they have easy access by televisit. Usually I would see them by televisit, and then whatever they need, testing, blah, blah, blah. And then I ask them to come to the office. But before they come to the office, I already talk to them, to the patient. Okay. All right. So just to tell you, you can, we're not going to discuss this because this is the protocol for the hospital or for the ICU. This is a completely different ball game. But as you can see, the methylprednisolone and ascorbic acid, thiamine, heparin are over, this is to cover the three components, right? The thiamine, you can use that even in outpatient. And the purpose of that is the patient oxygenation seems to improve when you use that. And then a lot of patients, they go into the hospital and ICU, they're also deficient. So that's the same vitamin that we use in people who are withdrawing from alcohol. So thiamine, you can use that in the outpatient if you want to take the B complex. It's included there, so you can use it. Okay, and these are the other agents that they've already included in the MATH plus protocol: fluvoxamine, cyproheptadine. This is a very old, the cyproheptadine is a very old medication. It's an antihistamine, but they are finding out that it has a very good anti-inflammatory action, or somewhat helping in the cytokine storm. And then there's also this anti-androgen agents. These are the agents that we use for prostate. If you have enlarged prostate, they use finasteride and ditosteride. And so that can also be used in the outpatient. A lot of my patients, since everybody has enlarged prostate, so a lot of them are already taking that. So that's that. Obviously, the famotidine, that is an H2, that is the for what do you call this, for acid in the stomach, to reduce an acid reducing agent. Okay, just to show you that's the hospital. Again, I'd like to emphasize that the disease, you have to control the inflammation, you have to control the excessive blood clots, and you have to manage appropriately and to control the very low oxygen level that these people suffer from. And so those are the three components. Remember that. Okay, I know this slide is very, very busy, okay? But I made this. You cannot find this in, I don't know, in the literature, but I kind of, my reference also is the work of Dr. Maric. He's our godfather in the FLCC, but it's not put in like this. Probably if you want a copy of this, because it's including everything, you can see the different phases here, up here, incubation, symptomatic, early phase, late phase, and this. And then you have the different severities down here. And then what happens during this phase is the viral replication, that goes down, and then almost non-detectable in the early phase. And then at the same time, you can see that the oxygen saturation, as the disease progresses, it goes down, okay? And then the inflammatory response, as the disease progresses, you see it goes up here, okay? And you can see that the delayed innate immunity starts here in the early symptomatic phase, and then the immune dysregulation is basically in the late, or towards the end of the early pulmonary phase, and it's really full blown in the late pulmonary phase, wherein the patient is already in the ICU. This is where you have the cytokine storm, the mast cell activation syndrome, the T cell dysfunction. So basically, it's a completely confused and raging immune system that is responding or reacting not to the live virus anymore, but to the debris. Look at this, the viral debris. It's very high here. We're in the early pulmonary phase, and that's where the immune system goes crazy. Okay, so in the post-COVID syndrome or the long hauler, you can see the inflammatory response. It goes down, but it doesn't quite go away, because that's one of the mechanism why these people continue to have symptom. And obviously the oxygen starts going up, but in a lot of people who got very sick, they don't go back to normal. And so in the outpatient, I give them supplemental oxygen. Okay, so it's a matter of time, depending on the course of the the long hauler, then that might eventually resolve. But it takes time. Okay, as you can see, there are a lot of people infected, and then they decline as the disease progresses, and there are only very few that go into the very late pulmonary phase, and a lot of them die. Okay, a lot of them die. And then again, in the post-COVID, more people are here because any of these people can develop the post-COVID syndrome. You don't have to be hospitalized to develop that. So it's going to be an issue if a lot of the young people develop this, because they can get debilitated and disabled. They are very tired, and they are having shortness of breath. They have headaches. They have aches and pains. They have depression. They have anxiety. Some crazy stuff. A lot of signs and symptoms that sometimes don't make sense and cannot be explained just by one disease area. Okay. So as you can see, I put it here. Bear with me. It's very busy. As you can see, I put the remdesivir here because it's antiviral. And then in the recommendation, treatment recommendation in the Philippines, it's nowhere near the this area. Okay, and I cannot blame them, because you're not allowed to give it on the outpatient. But here you can see asymptomatic. You have to use ivermectin. I use the monoclonal antibody. These are neutralizing antibodies. The patient really the patient gets better very quickly, like I don't know if it's something psychological to them, but after 2 hours, even before they leave my office, they're already saying, Dr. Villa, I feel much better already. Okay, so fine. And then you use the eye mask here, the eye protect for the Filipinos, and then mild severity is exactly the same thing. Actually, the monoclonal antibody is contraindicated when you are already in the moderate severity. When you already have the pneumonia, it's contraindicated because they get worse. And when you receive the monoclonal antibody, I don't advise them to get the vaccine at least for 4 months. 3 months is the minimum, and then I make them. I said go longer, 4 months, because they have two immunity. They get the immunity from the natural infection from the virus, and plus that, the monoclonal antibody is like getting a vaccine, and then it's effective right away. The antibodies are available to neutralize the virus, right? Makes sense. Okay, so moderate, you see, this is where you have to be very aggressive. I put it here. You see that arrow? O2 SAT equal to or less than 94%. You will hit them already. That's what I do. I hit them with the corticosteroid at this point, whether it's in the outpatient or they get hospitalized. I I had one patient. She didn't come to the office right away and went to the emergency room, and then they didn't give her any of the monoclonal antibody because she already had pneumonia, and she was just sent home like with nothing. And so she came to the office, she called me, and so I asked her to come to the office. I gave her methylprednisolone IV, and then I gave her high dose vitamin C, and then before the end of that week, she was already feeling better. I didn't have to give her supplemental oxygen, even though the oxygen was down to 94. But as day, progresses, the next day, then I was looking at the oxygen level and it was increasing. And then after I gave her every day the IV methylprednisolone, I switched her to the oral methylprednisolone. Okay. So as you can see here, the severe or critical illness, this is where you, as I said, we don't even talk about the virus here. You just will throw in anything to keep the patient alive, to save the patient. If they work, they work. If they don't, sorry. Okay, ivermectin at this point, there is a role for that because one of the function of ivermectin, it's not just antiviral, but it is an immune modulator. So it helps in reducing the release of the cytokine and the effect of the cytokine. Okay, so if you combine that, the ivermectin basically is applicable to any stage of the disease. You guys have to remember that, because if you review the mechanism of action of ivermectin, it has six. It prevents replication, it prevents the infection because it interferes on the S protein or the spike protein. Once the ivermectin is there, the spike protein cannot latch onto the cell, and so the effect doesn't happen. Okay, and if the virus is able to make it inside the cell, the ivermectin will stop the replication and two ways. Number one, it interferes with what we call polymerase, mRNA polymerase. That is the enzyme that helps the virus replicate. So if you put a stop to it, then it doesn't replicate. No, the virus has only two goals in life. One is to infect, and number two is to replicate. Okay, and if you keep on transmitting it, then they mutate. They mutate all the time. This virus, the coronavirus, is highly mutable virus. Unlike, what is it, like polio. We were able to eradicate polio with a vaccine because it's not mutating. we hit it with a vaccine and it's gone. And the thing to that is we use in this kind the PU, we use the live attenuated virus, whereas this our vaccine right now that is available, that's a different whole topic. The vaccine that's available is actually the synthetic one. We copied just because we have the technology and all, and there are a lot of controversies around there, but I'm not going to discuss that. Okay. And so that is we want to prevent the patient from progressing to this. Okay. So if we need to use prophylaxis even before the patient gets sick, that's what we have to do. And you have to target the people who are vulnerable, the people who are likely to get exposed, the people with what they call is comorbidities and things like that. And so uh, that's that. And then the long hauler is another. I'm treating people on long hauler, and it's also a different approach. There are different ways that you can treat these people. They are miserable. I use different agent. I still have the ivermectin. Sometimes I have to continue the corticosteroid because you can see that the inflammation is still, it's not very high, but it lingers, and so it makes you feel bad. So again, treating the long hauler is more like a multidisciplinary or multi-drug approach. But it's relevant in any stage of this disease. A healthy immune system is a must, is a must. And the healthy immune system is your first defense to this virus. A healthy immune system will make you not progress to the different disease severity. And then also, this is, I don't know if there are people listening who are familiar with the microbiome. The microbiome is the bacteria or the population of bacteria in our gut. They are good and bad, but mostly good. It's very important that to fight this disease, your microbiome is healthy. This is when you take some probiotic. It's very important because the microbiome is the one that's strengthening your immune system. The immune system starts in your gut. Before we were thinking that the center of the body, the center of your universe is the heart, because a lot of people are dying from heart attack. But the center of the universe in our body is the gut, because the immune system starts there. If you have a weakened microbiome, weakened gut, I assure your immune system is going to be low, and you're going to be susceptible to different kind of disease and different kind of infection, diseases including cancer. Okay. So I use some peptide therapy on this patient, and then they need a lot of rehabilitation. I put it there, I recover. That is the protocol that's being developed by FLCC. I think it's going to come out, I don't know, a couple of weeks or something. They're still debating. I get an inside scoop there because we do Zoom meeting once a week, and then they publish it. So I kind of get the inside scoop a little earlier than most people as a member of the FLCC. Okay, so try to look at this. I know you might get dizzy, look at it, but you are not going to find this in the internet, because I made this. I made it specifically for put everything together. Okay, and then just to show you, this is the recommendation in the Philippines. You see how naked or barren it is? You are going to get sick if you follow this. That's recommendation. And then, so this is a do nothing approach, and then focusing on the treatment, the late treatment, which you are not going to benefit so much more, because it's already I mean, the end stage. A lot of people will die when you allow them to go out. So that's the difference, okay? And just to show you, these are the hospital where I'm affiliated with, the Villages and Leesburg Regional Hospital. They're good hospital sometimes. And then just to tell you, this is very important. Knowledge is power. So whatever you learned today and what you've heard, please spread the knowledge, because that's how we're going to save people. That's how we're going to save a lot of of lives. And this is how you're going to alleviate your fear, a fear that paralyzes a lot of people. Okay? So, also, one thing is to remind me, um, what we do, it has a lot to do. We are all connected, basically. We're connected. Whatever you do to yourself will affect the environment. Whatever we do to the environment will affect us, our health. So I encourage everybody to also be aware. This is a wake-up call for humanity, I think, that we are not doing good to our environment because it's allowing virulent entities to grow and proliferate that we cannot take care of. And so the only thing that you can do, or the defense, the first defense, is to make yourself healthy and let it out there, make the environment healthy, and there's going to be a balance. We won't be able to get rid of all of this, and we don't want to get rid of them, but to be able to coexist without harming one another, because they are just beings or entities that are also trying to survive. But depends on what we do, then it causes disease, and then it causes a lot of crisis and heartaches and pain. And then, so that's what it is. We're all connected. We have to do something not only for ourselves, but for other people and for the environment. Okay? It's just like the microbiome. Our environment is like a microbiome. It's a microcosm, macrocosm, and then you have to take care of it so that it takes care of you. Okay, that's my practice.